This is Dr. Caroline Peterson and Natural Women's Health Institute in Sarasota, Florida. Today I'm talking about adenomyosis. Adenomyosis is a form of chronic pelvic pain. If you look at the uterus, you'll see that it's made out of different layers. So we have the endometrium on the inside, the myometrium, the muscle part, which is the bulk of it, and then the perimetrium, which is the outside part. So when we're talking about adenomyosis, we're talking about endometrial glands that grow into the myometrium. And so the most inner layer is the endometrium. Some of those glands go into the myometrium and live there. This can happen either in little spots, like little focal spots, or it can be throughout, can be diffuse throughout the endometrial myometrial interface. So when we're talking about chronic pain in general, we're talking about pain that is felt in the pelvis and lasts more than 6 months. This is something that affects about 15% of all women worldwide, and most do not seek care, which makes me think it's probably affecting more women than that, 15%. Chronic pelvic pain accounts for 10 to 20% of all gyne outpatient appointments. Up to a third of these women will receive diagnostic laparoscopic surgery to try to figure out what's going on with that chronic pelvic pain. And remember that it is surgery. Even though there's 3 little cuts in the belly, this is still surgery that can still be disruptive and is invasive and is, hard on a person. And yet it's what we have to offer for diagnostics in many cases. And even after everything, most of chronic pelvic pain is still unexplained. So this is a list of some of the top reasons for chronic pelvic pain: endometriosis, fibroids, musculoskeletal components, pelvic inflammatory disease, irritable bowel, painful bladder syndrome, pelvic congestion, and then psychological factors in addition to adenomyosis. The risk factors for adenomyosis are kind of changing. It generally appears in women of reproductive age, but at the upper margin. We're thinking that that's maybe a bit inaccurate, and we'll go into that later when we're talking about infertility. There seems to be a higher incidence in Black and Hispanic women over white women. Women who are at increased risk for adenomyosis have started their period early in life. They have a short menstrual cycle, and they've had more than one baby. Another risk factor for having adenomyosis is a uterine procedure or something that disrupts the uterus. So it could be a procedure like a cesarean or a DNC, or even pregnancy and birth, because those are disruptive to the uterus. It also looks like increased body mass is a risk factor for adenomyosis, as well as depression. It may not be a risk factor, it may be a cofactor. So a third of the women with adenomyosis are asymptomatic, and 2/3 experience symptoms like heavy menstrual bleeding, irregular bleeding, pain with period, and pain with sex, and also infertility. The signs of adenomyosis include uterine enlargement, and sometimes these patients will also have fibroids. And the picture on the right shows the different locations that you can get fibroids. Uterine tenderness will also occur with adenomyosis, and a boggy uterus will present, as well as infertility in some cases. So adenomyosis is called endometriosis of the uterus because they're pretty similar, but they do seem to have different origins. And so in that way, it's not the same thing. It's different. These ranges are huge. So that's telling us that, we don't know. We don't have a definitive study. So when you see wide ranges, it's basically just seeing the sample size is not large enough, it's not diverse enough, and so we really don't know what's going on. Otherwise, you would see a much more narrow range, and then you can be confident in what you're talking about. But with a range 25 to 70%, you can't be confident about that. But what we do know is that some percent of people with endometriosis also have adenomyosis. It's a little bit tighter range here with deep endometriosis, 49 to 66%. With deep endometriosis have adenomyosis, and that's about deep means that the endometriosis, the endometrial lesions outside of the uterus are about 1/5 of an inch thick. That's what makes it deep. So people are still trying to figure out adenomyosis. There seems to be a mechanical component and there seems to be a pathophysiologic component. So the mechanical component is, like we were talking about before, some type of injury to the myometrium. The myometrium is a muscle layer, the inner layer of the uterus. And like we said before, this could be cesarean, DNC, pregnancy, something like this. That causes the endometrium to then push into the myometrium. There could be altered lymphatic drainage, and that's could be in part why we see the boggy, painful uterus. And there could be like an early origin reason for it that has to do with the way that particular uterus developed when it was in its early conceptus. When we think about the physiopathological reasons for for adenomyosis, we're thinking about the sex hormone involvement, particularly estrogen and progesterone. We're thinking about inflammation and infection related to the uterus, fibrosis, and neuroangiogenesis and lymph angiogenesis. What that means is new formation of blood vessels and lymph vessels in relationship to the nervous system. So here we're going to talk more in depth about these mechanical theories. So here's a list again. So here's a picture of the list. So the endometrial glands are the inside of the uterus. These are the ones that are sloughed when you have your period. So if there's an injury of the endometrium and the myometrium, that's what this represents right here. With the injury, then what happens is these endometrial glands get pushed into this uterine junction zone between the endometrium and the myometrium, through that junction zone and into the inner myometrium to become adenomyosis. In the process of this happening, we're going to have micro damage to the uterine junction zone, which is the inner part of the myometrium that abuts the endometrium, and it will have lack of oxygen here. We'll also have inflammation because of the injury. There's going to be neurovascular support, which means that the body is creating a mechanism to try to heal this area, but it also can create complications in the process. And then as the body tries to heal, it's going to create fibrosis, and so that will create contractures. So that junctional zone, which is between the myometrium and the inner layer, or the deep layer of the myometrium, this junctional zone is very related, very sensitive to all the hormones, and it has its own way of moving. It's very important for moving the sperm into the uterus so that it can then later fertilize an egg. The junctional zone also is very important for embryo implantation, and it also influences menstrual shedding of the endometrium. So it's very important area of the uterus. So the uterus has several different peristaltic actions that come in phases of the menstrual cycle. So that if you're bleeding, then what the junctional zone does is it has peristalsis or movement patterns that go down because you're shedding the endometrial layer of the uterus. In the next phase, the follicular phase, when the body's preparing and getting ready for conception, the peristaltic pattern is going up because it's hoping to draw in sperms, that soon there'll be an egg that's ready, and it's getting everything set. In the luteal phase, that would be after ovulation, then what it wants to do is just maintain what it's got. And so that's why there's a small sort of outward movement pattern, because it doesn't really want to add new sperm. It wants to just take the odds with what it's got and see if it's going to be able to have a baby. Now, if you have adenomyosis, the junctional zone movement pattern or peristalsis is different. It's much more confused. When you're on your period, you're not only going to be trying to move that endometrial lining down and out, there'll also be some waves that go up. In the follicular phase, you'll be trying to create a cozy nest in preparation for fertilization, but you're also moving down. And then, of course, the luteal phase, you're not only like trying to get the other sperm to stay away, but you're also kind of sucking up. And so it's just confusion with adenomyosis, and that is because there's that thickening of the junctional zone so that it can't really move properly. So here's the picture. We have this is the uterus. We have the endometrium on the inside lining of the uterus. The next section is the junctional zone. And then we have the myometrium, the muscle that comes out, a layer away from that. So the endometrium and the junctional zone both originate from Mullerian ducts in the conceptus. The rest of the myometrium arises from the mesenchyme. So even though the junctional zone is a part of the myometrium, it actually has its origin in the same stem as the endometrium. And even though the junctional zone has a different origin than the rest of the myometrium, all the myometrium looks the same once it's mature. So this is one of the reasons for adenomyosis. The Mullerian remnants get caught up and later differentiate into something incorrect. So these are like stem cells. They're pluripotent cells that can turn into anything. And so about 6 weeks gestation, the conceptus hasn't determined what sex it will be. And if there's testosterone that's present, then the Wolffian duct will be activated to create the epididymis, the vas deferens, and the seminal vesicle that males will have. If there's no testosterone or inadequate testosterone is present, then instead what will happen is that the Mullerian duct will then be potentiated and will develop and will have fallopian tubes, a uterus, a cervix, and it will also form the proximal third of the vagina. And then the Wolffian duct will just be reabsorbed. So the inner layer of the myometrium, the junctional zone, is made out of Mullerian remnants, and so is the endometrium. And so if these Mullerian remnants get turned on in a woman and get confused and they think they're actually endometrium instead of myometrium, then that's one of the reasons that some people say you can get adenomyosis. So again, adenomyosis is if there is a tissue injury or something happens to the endometrial gland. This is a mechanical piece, and it's the tissue is opened up, the endometrial glands are pushed through that junctional zone into the myometrium. That's what adenomyosis is. In addition to the mechanical ideas of why adenomyosis happens, there are also a bunch of physiopathological reasons or theories about why it happens. So as we talked about before, this includes the sex hormone involvement, inflammation, infection, fibrosis, neuroangiogenesis, and lymphangiogenesis. We'll talk about each of those. So like endometriosis, adenomyosis is thought of as an estrogen-dependent disease. So like fibroids, these are conditions that pretty much go away. They self-resolve with menopause. So if you can make it to menopause, then you're kind of home free as far as the symptoms are concerned, because you got much less estrogen to provoke things. So what we do know about adenomyosis is that it has a higher expression of estrogen receptors, alpha and beta, and then the surface estrogen receptor type of thing. And so a higher expression means there's more of them. There's also upregulation of the estrogen receptor beta. And on the other side, we have deficient expression or possibly down regulation of the progesterone receptors alpha and beta. And then this will lead to progesterone resistance, where it's harder for that progesterone to do its job. This leads to estrogen dominance. The other thing that's happening is that we have poor estrogen metabolism. So this means that there's recirculation of estrogen in the body instead of being broken down and pooped out. So the genetic mutations or single nucleotide polymorphisms called SNPs that are common with adenomyosis are CYP1A1, CYP1A2, CYP19, and COMT158. All of these slow metabolism of estrogen. So it stays in the system longer and possibly even recirculates. Because estrogen is high and progesterone is low, we'll have an upregulation of prolactin. So what we don't really know exactly is if there is more estrogen, or is it just that the receptors are more sensitive and there's more of them, and then the progesterone has downregulation and fewer receptors, and so we have estrogen dominance, not necessarily because the body is making more estrogen, but because the ratio is off and there's recirculation of estrogen. So this is a picture of estrogen metabolism just to show you where the SNPs or the mutations occur. They're circled in red. And so basically what you're getting is a backup of the natural process of breaking down estrogen. And so in this way too, there's protracted exposure. Even if there's not more estrogen made, there's protracted exposure to the estrogen that is there. Another issue with adenomyosis, all the tenderness, is inflammation. And so there are more prostaglandins, the inflammatory PGE2 prostaglandins that are experienced by women who have adenomyosis. And this is thought to be related in part to what's called tissue injury and repair. So this is kind of going back to that mechanical model. And so it's a natural part of the healing process that if tissue is injured, it's going to be broken down. There's going to be inflammation that goes with that. And then things will have to get healed up. So part of this process increases the inflammatory COX-2, the interleukin 1B, and then we get the inflammatory prostaglandins, and then we get the liver acting up, and then we have more estrogen, and then we get more uterine contractions and bleeding and pain. And so this is all related to inflammation and possibly the tissue injury and repair cycle. So here's the picture of the tissue injury and repair and how that leads to inflammation. So this is talking about how it starts with a disruption of that endometrial myometrial interface that we were talking about. And then how you can get kind of like clotting, you get activation of the brain that then sends more adrenaline, noradrenaline, the prostaglandins, and then this will go down to other provascular inflammatory processes, making more vessels increasing estrogen, increasing the sensitivity of receptors, and then ending up in a adenomyosis. So the neurovascular system of the uterus is altered in adenomyosis. So the way the autonomic nervous system is set up is that vasodilation, pretty much anywhere in the body, is under the control of the parasympathetic nervous system. Vasoconstriction is under the control of the sympathetic nervous system. And so these things have to work together in order for us to get blood in the right place, the right time, and the right amount. And usually the body can do a pretty good job of this. But what happens is that when there is an excess of estrogen, or an excess, I'm not saying of the actual estrogen, but of the experience of estrogen, so it can be related to the sensitivities of the receptors, this decreases the number of sympathetic nerve fibers. So when you have a decrease in the number of sympathetic nerve fibers, what you're doing is decreasing vasoconstriction. And so then you have a relative increase in vasodilation. And so this is exactly what happens in adenomyosis. Because of the high estrogen, we have fewer sympathetic nerve fibers in the uterus of someone who has adenomyosis, and this is in part what leads to that vasodilation of the uterus, that bogginess. Another contributory factor to this highly vascular uterus is an increased expression of vascular endothelial growth factor, VEGF. So, of course, adenomyosis has not been well studied, but in a systemic review that was done, they found 5 studies that evaluated VEGF in women who had adenomyosis and women who didn't, and found that yes, there was more expression of VEGF in women with adenomyosis. So this is one of the things that contributes to the increased vascularity of the adenomyosis uterus. So one interesting way to think about the increased lymph vessels associated with adenomyosis is that, just when there's injury, that's when you get, you want to have more vascularization to bring in more healing factors and to take away all of the debris and so forth. Well, it's kind of similar with the lymphatic system, so that if we have inflammation, then the body will be like, hey, we need more lymphatic um, fluid there. We need more lymphatic vessels there to try to help boost the immune system, take away debris, help things improve. And so, I don't know if we should really think about these things as pathological, but it's kind of like the body is trying to heal something, but that the healing is like a little bit too aggressive, and so it's become kind of hurtful in the process. So we started out by saying that adenomyosis is associated with infertility, and in a way it's kind of confusing because adenomyosis is also associated with women who've had more than one baby, and it's primarily seen in women in their 40s. And so why is this associated with infertility? So about 20% of women with adenomyosis are under 40, and the rest of them are between 40 and 50. And so the idea is now we're starting to see younger women with adenomyosis, not because it's a new thing, but because women are putting off pregnancy until their late 30s or early 40s. And so then these women are more likely to have infertility associated with adenomyosis than younger women who are infertile. So there's several different reasons that people think adenomyosis could be related to infertility. It could be because of the intrauterine abnormalities, altered endometrial function, impaired implantation, or chronic endometritis, which is an infection of the endometrium. So when we're talking about intrauterine abnormalities and their relationship to infertility, we're talking a lot about fibrosis. We're talking about blockage of the fallopian tubes, ovarian adhesions. We're talking about fibrosis altering peristalsis of that junctional zone and creating abnormal sperm transport. So adhesions, 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 fibrosis, fibrosis, fibrosis. So we do know that we do have that thickened zone of the myometrium. That junctional zone thickens up in relationship to adenomyosis. The abnormal peristalsis, like we spoke about before, and how that impacts the sperm transport and decreases fertility. The endometrium itself has altered function, in part because of inflammation and the body's response to try to take care of inflammation, the increase in oxidative stress and reactive oxygen species that are toxic. Those things are toxic for the embryo. And then we have the abnormal steroid metabolism, where you don't have the right ratio of estrogen to progesterone. And then because there's high estrogen and low progesterone, we have high prolactin. And prolactin tells the body, you don't need another baby. You're fine just like you are. And so then the body's like, not a good time to make a baby. And so that's another cause of infertility. Impaired implantation also occurs with adenomyosis. Again, the inflammation. So the inflammation is really a part of everything. So if we can take care of the inflammation, we will be taking care of a lot. We also have the impairment of the blastocyst. That's a very, very early conceptus that's trying to implant, but these adhesion molecules called integrins there's not enough of them, and so the blastocyst can't implant right, and so then you have a failed conceptus. This gene, HOCK10, is required for embryologic development, but it's altered, and so then you can't really have good implantation. And then there's another marker called leukemia inhibitory factor that has to do with basically everything related to implantation. And that one's not working right. And so again, you have low implantation, impaired implantation. And then the other reason for impaired fertility with adenomyosis is this idea of the uterine infection. So something that's unresolved or something that hasn't been diagnosed and hasn't been treated will create inflammation, and then that will just keep going if nobody even knows that it's there. The way adenomyosis is diagnosed is not not by a physical exam or by lab findings. There are no markers that we look for in the lab or physical exam. Instead, it's imaging. Imaging is what's used. And so the screen is a transvaginal ultrasound, a 2D or 3D. And then what they're looking for are the shape of the uterus, that's more globular, more fan-shaped, and difficulty differentiating the strata of the uterus, and possibly cysts. But because fibroids are co-occurrent so much of the time with adenomyosis, and they can look like the focal adenomyosis lesion. A lot of times people end up getting a pelvic MRI also, just to make sure that they're looking at adenomyosis instead of a bunch of fibroids. So as far as biomedicine is concerned, there's no FDA approved treatments. However, there are a lot of treatments that are recommended. NSAIDs or anti-inflammatories are first line of care. And then the next line is to suppress menstruation. They may do that with the IUD, the progesterone high IUD, or oral contraception. They can also use the gonadotrophin releasing hormone analog that will downregulate or inhibit the hypothalamus pituitary gonadal axis. They may also use an antagonist to the gonadotrophin releasing hormone that will inhibit hormones from binding to receptors. But in most cases, women will end up with a hysterectomy. And it's not clear if this is because other options were not adequately explored, or because women are so miserable that it seems like it's worth it. So the natural approach to adenomyosis is basically looking, understanding the same causal factors, but trying to treat those with more natural ways. So for instance, for adhesions, for fibrosis, then we use a lot of castor oil packs, because castor oil packs are really good at breaking up adhesions, kind of melting them away. And then I use visceral and vascular manipulation to try to optimize movement of that system, because if it's adhesed and not moving properly, you're not going to get proper drainage of the area, and that can also contribute to pain and dysfunction. We also want to improve the metabolism of estrogen by doing detox for the liver. So we have actually like 4 phases of detox. So you have to be pooping at least once a day. That's the 4th phase of biohepatic transformation. You have to poop. If you're not pooping, you're going to be plugged up with way too much estrogen. And then behind that, we have the gallbladder. The gallbladder has to be working. It has to be squirting. We need that bile moving through, because that's taking out the old estrogen. We need to get that pooped out. And then we have 2 phases of biohepatic transformation in the liver. So the liver has to be up and chugging away. And a lot of times, because there's so many genetic SNPs, then we're going to have to augment the cofactors and the support that the liver gets for detoxing. And so one of the things we use for that is DIM, which is made out of broccoli and is really, really good at helping to break down estrogen. Another thing that we want to do is to downregulate the receptors, because one of the big things in adenomyosis is that the receptors are way too sensitive. And so we downregulate them by using things like genistein and diadesin, which come from soy, and they are called adaptogens. And so they can act as weak estrogens to plug up the receptors, so that the strong estrogens that your body makes won't plug in and give you that estrogen excess symptom. The other thing that we can use to support are phytoprogestins, and these are just barely being explored right now. This is kind of like a new frontier in natural medicine, but this could be helpful because this is a problem with either low progesterone or poorly elaborated progesterone receptors. And so if we can bring in a little bit more oomph to this part of the sex hormones, then that could be helpful. We also definitely have to treat inflammation. And if there is an infection, it needs to be treated. So a lot of times we'll use natural antimicrobials to treat that infection. If it were, of course, something aggressive, then, it's okay to also not use natural things. It needs to be taken care of. And then a big thing for any of these, like, estrogenic, estrogen excess type of conditions, is to modify environmental exposures, because our environment is very estrogen rich. And so a lot of times it's not enough just to work with the body. We have to work with the environment in which we sit also. So just because the phytoprogestins are a little bit less researched than the phytoestrogens, I wanted to talk about them for a minute, and go into each one of these four just a bit. So camphorol is actually a flavonoid that is found in ferns and conifers, rose, hydrangea, a bunch of other flowers. And it inhibits the receptor alpha and reduces the expression. So you could see this could come in handy, right? When we're talking about adenomyosis, because we're having a lot of overexpression and hypersensitivity of the estrogen receptors. And it also impacts cell proliferation in the uterus. And so that sounds pretty awesome. We want to decrease proliferation. And so this could be something that potentially would be helpful. Apigenin is another phytoprogestin, and this is good. It's an anti-inflammatory. This is chamomile. So in Latin American folk medicine, chamomile is pretty much a panacea. And it turns out they're right. What can't it do? What can't chamomile do? So it's an anti-inflammatory, it's anti-proliferative for the endometrium. It works as a weak progestin or a weak estrogen. It inhibits that vascular endothelial growth factor. And so it pretty much does a lot of stuff. And then it's broken down into luteolin. Now, luteolin is not quite as rosy as its precursor. And in fact, it's called a promiscuous endocrine disruptor because it too can do many things. So my way of thinking about it is that probably this one needs to be researched a little bit more in order to understand what it's appropriate to use for. It's probably not, its functions are probably not well enough refined in this category of use at this time. And so it's probably perhaps better to kind of focus more on eating lots of fruits and vegetables, nuts and herbs, instead of maybe taking straight up luteolin until we have a better understanding of exactly how it works. So the last phytoprogestin that I'm going to talk about is the naringenin. And this is the one that gives the bitter taste to the pith of the citrus. And it's a weak progestin. When I was a little girl, my dad would always say, you have to eat the pith. And so every time we had one of those delicious navel oranges that was so sweet and juicy and had so much pith, so much of that white stuff, We'd have to just bite through it and eat all that pith in order to enjoy the juicy, sweet orange. And my dad was right. My dad was a naturopath chiropractor, and we ate that pith and we got all that great flavonoid, antioxidant, immunomodulatory, anti-inflammatory, nephroprotective, hepatoprotective, neuroprotective, anti-diabetic, anti-tumor, anti-atherosclerotic. Jeepers, what doesn't it do? Eat your pith. Eat your pith. Antifibrotic, reduces oxidative stress. Jeepers. NF kappa beta. Wow, this is a heavy hitter. 1 orange a day. Maybe you should have 1 orange a day with the pith instead of an apple a day. What do you think? So some of these environmental influences of the neuroendocrine system are those persistent organic pollutants. They're terrible, man. The dioxins, the PFAS, the phthalates, the PCBs. They include medicine and phytoestrogen in here. I really think phytoestrogen is different because nature has a way of balancing itself. And when they're talking about the medicines, what they're, I think, talking about in particular is how the medicines are discarded and then they get into our water and then everybody's drinking all these hormones accidentally. But yeah, we're exposed to all of these endocrine disruptors because herbicides are all over the place, bleaches and paint, plastics, so many chemicals that we're exposed to, so many things that we use in our everyday life, like stain repellents and nonstick pans, cosmetics, and all of these persistent organic pollutants, they become concentrated in the environment, whether it's the water or the fat in animals or the bottom dwelling fish, including the shellfish, and so these are things that are, pretty much impossible to avoid. And so we just have to do the best we can to try to decrease exposure to the best of our abilities, and then have a real good plan in place for detoxing on a continual basis by eating lots of fruits and vegetables, and maybe even adding in some botanicals and things to support the detox systems of the body. So in conclusion, for treating adenomyosis, what I recommend is trying conservative management first. But it's not a walk in the park. You have to make changes in your lifestyle, and you have to go through this process of castor oil packs, visceral manipulation, and that can be painful to break up adhesions and stuff like that. There's supplements. We use the plants and vitamins and minerals and stuff to support detox in the body, and to block those receptors and optimize ratios, and then to put into place other lifestyle practices that will decrease exposures to environmental xenosterols. But if you're willing to do the work, then it's probably worth considering a trial of therapy with conservative management of adenomyosis. This is Dr. Caroline Peterson with Natural Women's Health Institute in Sarasota, Florida.